So thanks, everyone. I'm going to be filling in for Andy Hill. He recorded his presentation after he realized he had COVID, but we had some technical problems. So I'm going to skate through the slides, so forgive me if I don't get them right. Some of the data has been already presented, so I'm just going to flick through it because I think we can save some time. So as Lloyd actually presented some of these first-line treatment guidelines earlier. Next slide. Sorry, it's me who controls them. So TRIO took the three studies that you heard earlier about, the advanced NAMCEL and Dolphin 2, and tried to bring together some of the data and to see what we could tease out from that, particularly as we were rolling out dolutegravir, which was a game changer in terms of the region. Sorry, now I'm going too fast. There were several other independent trials. You've heard about all of them over the last few days, and the ones mentioned there at the bottom. So Bronwyn's mentioned some of this stuff in her presentation around the fact that the combination of TLD has really yielded these incredibly good outcomes in terms of the safety, efficacy, and persistence of TLD. The weight gain story is not over yet, and Tembi addressed it this morning. It's a complicated story. Again, we've seen the slide already with significant weight gain on both the TAF containing the tenofovir containing regimens when compared to efavirenz. And with it has come, as you'd expect, a rise in metabolic syndrome, which is a significant risk factor for cardiovascular outcomes. The risk, though, is driven by weight gain. What we are starting to see, though, is hypertension. NAMCEL showed a very similar change in weight change, and with it as well, the rise in metabolic syndrome. And what we're seeing in NAMCEL, though, is greater hypertension. In advanced patients who are treated more aggressively for hypertension, because hypertension therapy is much more available than in Cameroon. I'm not sure why it keeps changing itself. What we also were able to do with these three studies is to look at outcomes in pregnancy, because we were dealing with, in all three studies, well, obviously in Dolphin, but between these three studies, there were a large number of pregnancies. We were able to amalgamate the data and start looking at outcomes. Now, there's still not enough adverse outcomes to make any inference about dolutegravir being better or worse than efavirenz, but we're adding to the pool of data that's coming out of that. And so far, it is generally quite reassuring. So there are other studies that are coming through, and you've heard, as I said, from all of them in terms of these patients, generally in comparison to NNRTIs. I think what we are seeing in general is that dolutegravir is performing really, really well. I think you've just heard about DEFT, where there's a slight benefit to adding on darunavir to dolutegravir alone. But across the region, this movement from efavirenz to dolutegravir has been pretty much a public health triumph. We are seeing almost no dolutegravir resistance in these following 6 key studies. And I think, again, this is really important. Nick took us through some of this data. And people keep saying to me, we're going to see resistance, we're going to see resistance, and we are going to see resistance. I'll show you some of the cases that we are seeing, but it is truly remarkable when you see how quickly we saw resistance, even with the protease inhibitors like Eluvia when it was introduced, compared to what we're seeing at the moment. So Andy pulled out all these cases of resistance, and Nick's talked a little bit about this, and his studies certainly have informed us. And we do need to keep a really close eye on these resistance programs. But it is still, compared to the scale of the programs, we're not seeing it yet as something that we're going to have. I mean, in some ways, having such small numbers creates a real public health headache, because to find these cases is actually really hard. And to decide how to funnel them into programs is difficult, and what to do with them. But the numbers that are showing up as with resistance is very, very small at the moment. It's not something to be dismissed, but it is something that is very, very unusual. So in 2013, we had this first, second, third line transition, which worked actually very well in South Africa. This is how we structured the patients, and in many countries in places like Zambia also had a very good third line program, and some of the other countries too, and it worked very, very well. And now we have this situation where patients are steadily moving on to TLD, and certainly in our program, we've moved patients on second and third line increasingly across onto TLD. And the numbers actually on second and third line have steadily gone. The problem is that we are putting all our eggs in one basket, and if something goes wrong with TLD at any one point, we are in a lot of trouble. Now, having said that, we have rolled out to tens of millions of people, and we haven't seen terrible things happening at the moment. We've got all these good things happening, and we're seeing really good safety, particularly in pregnancy, which is always something that's understudied in the richer countries. The other good stuff that I've mentioned. But the things that we do need to continue monitoring is the longer-term drug resistance, and I'm happy to say that everyone's on the lookout for that. But we are seeing this stuff around weight gain, which is very complicated. I don't think it's because of dolutegravir, and I don't actually think it's because of TAF. I think it's got to do with complex changes in food and how we eat, and also to do with HIV itself. But we are seeing this rise in hypertension associated with certain cohorts. We're not entirely sure if it's because of dolutegravir or not. There's a lot of people starting to look at that. The metabolic syndrome, and whether we're going to see the same consequences that we see in Western populations. And finally, you never know, are their livers going to explode and their brains going to explode? If something does crop up, we are incredibly reliant on this triple combination. So to be very vigilant and to have all of ourselves in a position where we're able to work, to be thinking about what would we do if we do have to step back from this combination is really important, and to continue to be focusing on safety as we go forward, like the TRIO analysis has done. Thank you very much.